more of a generic issue, which is affected
Uh,
by all of us, and affects all of
exactly.
us. So both
Exactly.
the things. So it's a very generic topic, not a very specific.
Actually, actually, tobacco and smoking, it doesn't affect only those people who are consuming it. It also affects the surroundings. Also
Yeah,
affects everybody else. It's
Hello,
a
yeah,
public
package
health
smoker.
issue. It's a public health
exactly.
issue, and yeah, and it's a nice thing that we could get somebody from northeast to, should I say, Chandigarh is northwest. It's a vast area connected in between. It's a very interesting in that way. So
Correct.
I asked I asked someone to one Mr. Shomiran Maiti to, I do not know why his phone is. Shomiran, can you hear me? Shomiran? Okay, and I cannot now. I just see someone's head. That is probably Samirans, but I can't see. How do I get into present now? Your entire screen window? No. How can I see everybody over here? I don't change layout. Full screen change. I don't see anybody else. Is it Samiran? On the okay.
He seems to be there. I can see him on the screen.
Yeah, but one of the things I don't see the whole screen. Okay, Dr. Priya, would you introduce yourself?
Sure. Um, Shyam, thank you very much for having me here. I'm a dentist specialized in oral diagnosis and radiology from India. I've been a clinician and been an academician for past 18 years. And now I'm pursuing a PhD where I'm developing an epidemiological model to detect precancers, how we could develop capacity to reach the unreachable rural areas. My study with which actually this is based on one of my earlier papers where I have uh, enormously written that tobacco control in India especially should be combined with cancer control.
Yes.
So this is to build capacities in urban and rural areas to tackle tobacco and oral cancer concomitantly. So apart from my PhD, I also network and I'm into I have started a social
তুমি কি
enterprise.
ইয়েতে আছো? তুমি
Yeah.
রেকর্ড করছো? আচ্ছা ঠিক আছে, আচ্ছা ঠিক আছে। I mean, now I see only my head and nothing else. I don't know why.
Sam, if you click the center of your screen, you may get to other people on the right hand side in a bar.
Yeah, I get the right hand people on the right hand side, but I cannot change. I cannot see others. That is something which is bothering me.
You
Okay,
have actually pinned yourself, Dr. Sham.
that's right.
Unpinned.
That's right.
Yeah, right in the middle.
Okay. Got it. I'm supposed to be the technologist, and I'm the most naive in technology.
No, this is
Thank
not
you.
actually. This is not actually technology. You might be doing lot. better than that.
I'm I'm an armchair technologist in that way. Okay, so, Chiranjit, did you
Yes,
introduce yourself?
yes.
Okay.
Let's get started. Then means
Yeah,
formally
yeah.
started.
Yeah,
It will be.
let's get
Let's
started.
yeah
Chiranjit has a some kind of a Chiranjit has a okay.
yeah.
I, I I I I didn't introduce myself, did I? I'm Sham Chakraborty. I'm the founder of Trinnect Limited, which is a company in Finland, registered in Finland, but I work in India. Particularly, I'm trying to get healthcare services in rural India through telemedicine, and I have a few other ideas also. For example, um, trying to generate awareness among people through webinars and and there are a few other things also, and we get many more ideas through all these interactions and see. So, so please, Chiranjit, Atri,
Yes.
you joined right now. Could you introduce yourself, Atri?
Hello, I am Atri Kundu and I have just admitted to NRS Medical College this year.
So you're a budding doctor,
Yeah.
and yeah, and you'll see there is some senior doctors here, like Professor
Hmm.
Sandeep Raha from UK, Professor Sonu Goel from PGI Chandigarh, Dr. Chiranjit Neoatia, and Dr. Priya. Dr. Chiranjit is from Agartala, but he is now doing hospital administration in TIS, Bombay. Dr. Priya is doing his PhD in oral cancers in remote areas. Am I right, Dr. Priya?
Yeah, my study is from India, but I'm at New Zealand.
Achha. And Rupayan is also here. I think Rupayan could talk about himself. Rupayan is Rupayan is our close friend. Hello, Rupayan.
Hello, Dr. Sam. I should.
Yes,
Yeah, I think we should get started, and all
yes, yes,
others who
yes,
are not speaking,
yes.
just a ground
They'll
rule.
come and
Yeah,
join. Yes, yes.
just
Please.
as a ground rule, all others who are not speaking, they can mute themselves so that during discussion it does not disturb, means other sounds does not disturb. So
Yeah.
let's get started. So good evening, ladies and gentlemen. Good afternoon. Somewhere it will be afternoon. So welcome to Trinect's third webinar series. This is on tobacco and smoking. We have with us Dr. Professor Sonu Goel and myself, Dr. Chiranjit Neoatia, your host for this session. Before starting our discussion, I will take the honor to introduce Dr. Goel formally. Dr. Goel is a professor of health management in the Department of Community Medicine and School of Public Health of the prestigious PGIMER Chandigarh. And he has completed his MBBS and MD from IGM Medical College, that is Shimla. He has also done his PG diploma in Human Resource Management from Symbiosis Institute, Pune. And recently, he has also completed his PhD in Health System Research from the University of Maastricht, Netherlands. Dr. Goel is a keen researcher and has published over 150 articles in the form of research paper, book chapters, and he has also completed over 40 research projects as principal investigator, which are sponsored by WHO, ICMR, Department of Science and Technology, NHM, NRHM, and PGIMER Research Scheme, Ford Foundation, NSSRC, various institutions. His main interest lies in public health, health management, especially focused on human resource management and operational research and the tobacco control. Dr. Goel has held various academic positions in his career, also has served as Deputy Medical Superintendent in the PGIMER Chandigarh for 3 years. He has been acknowledged as outstanding performer in administration, teaching, and research. Besides serving as professor in the School of Public Health PGI Chandigarh, Dr. Goel also serves as director in the e-resource center for tobacco control and also CB editor of the Tobacco Free Time, the bi-monthly publication from the Research Center from Tobacco Control. He also chairs the Tobacco Control Union, the global scientific organization working to improve health for people in low and middle income countries, which particularly focuses on TB, tobacco control, and lung disease. We can clearly see that the topic of tobacco is very close to that of Dr. Goel. And myself, Dr. Chiranjit Neoatia, I have completed my MBBS from Tripura, Agartala Government Medical College. I am in the government medical service, but now I am studying in the Tata Institute of Social Science, Mumbai, Master of Hospital Administration. So that is our introduction, but let's get into the main discussion. So on the tobacco and the smoking, if we see the historical part, that the history that dates back to as early as the 5000 and 3000 BC. And for the most civilization, it started as a religious rituals, the tobacco consumption, which most of which we still see today in various social functions, like especially in marriages in India, where pans, bitter leaves are offered as customs in the higher societies. They offer cigars and like that. And pans have been some kind of dessert in the Indian community that it is consumed regularly after food. That even my parents used to consume some now. Now also they lessen, but they still consume. And that addiction is so. By the 1700s, the smoking had become more widespread across the globe, and the tobacco companies have developed the industry that gained a lot of power to influence the government functionaries and to expand their customer base. So I'll ask Dr. Goel to share some light on this, like how it came into being the present from the epidemic of tobacco use. Dr. Goel, over to you.
Thank you, Dr. Charanjit, for a very generous introduction. And thank you, Dr. Sham, for organizing this wonderful webinar. And rightly said by Dr. Chiranjit that this topic of tobacco is really close to my heart. Although I have not working it for many decades, but I started this journey about 10 years back. I was invited by one of my colleagues who have shifted. I was in Medical College Tanda as a faculty in Himachal Pradesh. So there, one of my colleague, Dr. Rana J. Singh, who was a pulmonologist and who has shifted to International Union Against TB and Lung Diseases, actually invited me to be a part of discussion in Thailand. So that was my first journey, actually, my first orientation towards tobacco, and I was introduced to Empower strategy. I'll be telling you later what is Empower in tobacco. So there my journey starts, and in the first meeting itself, it becomes very close to my heart that why people are dying because of no fault of theirs. So just they are dying because of tobacco use, and what we can do as a public health specialist in tobacco control. And thereafter, I focused my one of my area as tobacco control. So thank you for organizing this webinar. So I think many of you might know a bits and bits of histories of tobacco, but I'll just elaborately in bit little bit more elaborate so as to understand that the tobacco was not only a part of custom culture but also religions, and it has been there as a lot of system. Like I will tell you that it was like the barter system where the exchange system occurs. So it started with tobacco. So there are very interesting history, and it started around 8,000 years back, and it was in highlands of Peru, South America, where it actually initiated, and then cultivation started in Mexico several thousand years back. And then, as I said, that it was like in barter system. Barter system is exchange system. Like people used to give their wheat, rice in exchange to tobacco. So in American Indians, it was used as a barter system way back 6,500 years back. So it was long back that barter system has actually originated. And then in that American Indian tribes, it becomes a part of their religious, cultural, and social rituals. But we know about tobacco from 15th century because everybody knows Christopher Columbus, who discovered tobacco. So we didn't know about American Indians. So this Christopher Columbus actually discovered when he was on the way to find out the world basically. So Native Americans gave him a gift of tobacco, and he threw it away. When the tobacco was given to him, he actually threw that tobacco. And then soon after, like the sailors who were traveling with him brought tobacco in his ship. It was not Christopher Columbus actually who brought tobacco. It was the sailors who was traveling along with. So they brought tobacco back in Europe, and very soon that it has become very popular in the Europe. And at that point of time, the popularity was not because of its addiction property. So at that point of time, the it was due to the medicinal properties of tobacco. So it becomes popular because of its medicinal property. And there was one doctor, Conrad Gesner, so who reported that chewing or smoking a tobacco leaf has a wonderful power of healing any illness. So basically, at that point of time, there was some other addictions. So it was considered to be a very safe addiction at that point of time, a peaceful drunkenness. So he termed tobacco consumption as peaceful drunkenness. And thereafter it started, and then at that point of time, I think those who are medical specialists here, they might know the anatomical snuff box. That this one. So we used to see in the anatomy that we have anatomical snuff box, but many people might not know that how it has become the anatomical snuff box, because sniffing, the sniffing of the tobacco leaves, that's as smokeless tobacco products. So they used to keep in that snuff, and then they sniff. So it's basically that because of that sniffing, keeping that, it is termed as the anatomical snuff box. So this is one of the other importance. Another interesting thing which I want to tell to you is in the World War. In the World War, the First and Second World War, it lasted for many years, and then there was shortage of grains at that point of time, and the soldiers were not getting the food. So at that point of time, the it was given in rations. This tobacco, many people knows about it. So, but this was given as rations rather than grains because they don't have this food to eat. And why it was given in rations? Because that it actually quenches the thirst as well as the hunger. So people do not become hungry after eating that. So thereafter it becomes popularized at that point of time. So cigarettes again was included in the ration, and I think till few years back, I'm not sure about right now, even in the canteens, Air Force canteens and army canteens, it was still being given as rations. I don't know right now what is the status. I think it is not being given, but it was the status. If we talk about India, how it has been introduced in India. So it was introduced in Bijapur. I think many people know about Bijapur. It's Maharashtra. So Gujarat, somewhere between Maharashtra and Gujarat, in the kingdom of Adil Shahi. So it was in 17th century actually, through Portuguese traders, it is being introduced in India. And then it was Akbar who introduced this pipes for smoking. So he was a grandiosity sort of king. So he used to take those pipes, and he introduced the in a bigger way. Akbar was the one who introduced, and Jahangir. Jahangir was the one who abandoned this tobacco. So Akbar introduced it, and Jahangir was the one who doesn't like that. And this was how, I think, in brief, there are a lot of things to be told about historical aspects of tobacco, but to make the things interesting in this webinar in the initial part, so I just thought of introducing some of these concepts.
Thank you, sir. Thank you, Dr. Goel. So you have mentioned that there is smokeless type also, and there are major two forms of tobacco product, like smoking type and smokeless types. Can you enlighten us elaborately? So there are many different forms like pans, also gutkhas, and different forms so that audience become aware.
Right. So I think there are multiple types of tobacco, and India is one of the countries which is largest and second largest producer of tobacco. And another distinction which India has is the variety of products. India has the largest variety of the products, especially smokeless tobacco products. You go to any state and you travel within the state 50 miles, you find a different variety of tobacco, especially smokeless one. And if you see, the smokeless one ranges from like there are Khani, Gutka, and Dr. Chiranjit, you belong to the Northeast, so there are a lot of practices, and maybe you can also chip in between
Yes.
that,
Yeah.
if I'm wrong, that there are some paste which is available there, and which they people like which we apply on the in the gums, and they keep on dissolving it throughout the day. So it's like a toothpaste, and there are many multiple things which are there in smokeless tobacco. If you see smoking, so smoking, although not many varieties are available, but BD, that the poor man's cigarette is very popular, and it is even popular with the governments. And why I'm saying that it is popular with the governments, because they are not raising the taxes on BD products, and that's why it's very cheap and it's easily affordable to the poor people, and people can easily consume that. So that is another thing which is very dubious and unique in India. And we find the third thing which is there as hookah. Now in newer generation, this hookah or pipes of smoking, pipes and hookahs are there, and it is being deeply entrenched in the cultures. And if you see in the COVID times, uh, this hookah is very dangerous. If because there are very in hookah there are few things which are very famous, that people used to sit together and then they consume hookah. So that again predisposes an individual to contract this COVID. Second thing is they share the pipes, and they always believe that by sharing the pipes among themselves, they share the love within themselves. So that is one other things. So one, if he's sharing the pipes, so then it is a direct contact of saliva with the other people, and that's another reason for why COVID is there. So these are the things which are there. And now the another dangerous thing which I'll be talking in detail maybe towards in this webinar, is about, let's say, from China, and then it is now spread all over. and you see the prevalence of electronic cigarettes are going quite high. So we'll be talking in detail what are the harms of electronic cigarette towards the end of in this webinar. So what I'm trying to say is we have a variety of products of tobacco, especially the smokeless tobacco products in our country. So Chiranjit, you can add upon if you
Yes,
want
yes.
to.
Yes,
Uh,
actually, in the hookah type you have mentioned, actually in our tribes, means in the tribal
Chiranjit,
area.
can I interrupt Chiranjit here?
Hello.
Yes, yes,
Now,
yes.
now,
Now it's
I'm
yeah,
okay.
wonderful. Thank you.
So yes, in the our culture, means in the tribal culture, so they have this hookah type, means it is like kind of desi products. So they have not the hookah that we see in the internet, means as in the bars. So they have used from the bamboo product in the bamboo traditionally. So they have used on the bamboo, and they put some water in there on the and they use the tobacco leaves, and they burn and they inhale it. So that has been used in as a cultural many functions regularly. I have seen my grandfather, my grandmother used to smoke like from the childhood also. I have seen using that. So those are very popular. Means the cigarettes and those beers did not come, but those practices were in the raw form. They used to be consumed like that way.
yeah, yeah,
And the pan is the very raw, means it doesn't need much manufacture, means like corporates, like the tobacco corporate giants, they used to not unlike cigars, they are very available in markets, so on a very cheap rate. So they used to be consumed like after food every meal.
Yeah,
right,
can I, if I can say two words. One thing is that before this smokeless tobacco, which in Finland or in Europe, I think it's usually known as VAP, and I think something like Vaporate, shortened is VAP. In between came this kind of chewing gum with a lot of nicotines, which is called Nicorette, as a some kind of a how to get rid of smoking. But people started getting used to this chewing gums itself. I mean, they started getting, and then the next stage came this VAP, and I would like to know more from Professor
yeah,
Goel about the different
right.
issues of VAP.
Yes,
And
actually,
about hookah, it's interesting that in West Bengal the hookahs are made from coconut shells, and yeah, and you put there are three holes as such on top of it, and you put in one hole you put a stem, and then you put some kind of a I mean clay pipe, and on top of you have this burning tobacco, and from other hole you puff it off, and even people say that this water from this hookah, which you through which the smoke gets filtered, it's very useful in different. It has got different medical usage. I'm sure that Dr. Sandeep Raha has enough information on that, and I'd like to hear about it. He's the senior most. He's even senior than me, so he's good. So please go ahead, Sonu.
Yeah. So I think rightly said, Dr. Sham. So I was talking about this vaping, which you are saying that it's basically electronic cigarettes, which has come, and which people, even the cigarette companies, would like us to believe that this is safer alternative, and it's a harm reduction. And you might see that they are promoting this electronic cigarette as a harm reduction device, which is not actually true. It is, as you have rightly said, that and in US and in many other Western countries, there was a disease, evalis, which was there, a lung disease, a pulmonary disease, which was there and which killed many people, and especially the younger generation with that evalis, which is caused by this vaping of electronic cigarettes. So this is absolutely wrong statement of the electronic this tobacco industry, that it is a harm reduction. It in fact, because when there is a specific curve in which tobacco epidemic grows, and it has almost reached the peak now. And now in almost many countries, 60-70% of the country, which includes India, the peak is going down. It's a tapering, now it's going down. Now the tobacco companies are worried that this peak will go down, and we don't have business left later on. So now they're focusing upon two things. One is promoting the cigarettes and these tobacco products among the females, where the peak is still going higher. And second thing is promoting electronic nicotine delivery systems. This is ends, or electronic cigarettes, where they just want to start, and again want us to suffer for next 60 to 70 years, which our generation, last generation, has actually suffered. So this electronic cigarette or vaping is really dangerous, and it contains pure nicotine. Actually, it's like a pen. If you can see the electronic cigarette, many people might not have seen that. It's like this pen. There are many devices. So if you just open this, it's open like this, and you open the pen, you fill the cartridge with nicotine, you close it, and then you can have, there is a button over here, you can just, people can smoke it. Even the younger generation in US and Canada and many other countries, people used to keep the mouth we used to keep in the this thing in our childhood days, no, we keep our pencils like this. So they used to keep it like this, and they keep on smoking. So even the people don't know what they are doing. So it's really very dangerous. Yes, Dr. Sandeep, want to add?
Yes, I mean, as you said, electronic cigarettes in UK at least, there is slowly the law is coming on electronic cigarettes as well. It's banned from any public buildings anyway, like cigarettes, and it's in some places it's actually banned even outside. But one thing is very interesting as far as the tobacco is concerned, that the tobacco use, at least in Western countries, have gone down significantly because of taxation, in addition to the health promotion. And the taxation has become so heavy on, particularly on cigarettes and tobacco products, that many people can't even afford to buy it. I have got many patients. Just few months ago, I met a patient in the hospital who is smoking 60 cigarettes a day. So I said 60 cigarettes a day in UK terms is 30 pounds a day. So he has to spend 30 pounds, which is equivalent to, how much is it? Is 3,000?
Yep, somewhere like
3,000 rupees a day to smoke his cigarettes. And that is almost equivalent to his old age pension a British government gives to all pensioners. So I think the taxation has got significant effect. Unfortunately, as you mentioned, and Chiranjit mentioned, that BD is so cheap and without taxation, so that there is no incentive. And in addition to all that, all these big tobacco farms, most of them are American, and they started building factories in China and then promoting it in India as well as a cheap product. They had a huge political lobbying. They're lobbying in political institutions, in parliaments and different countries. Lawmaking um, organizations was massive, but that is slowly coming down because of the people's awareness and
right.
anti-tobacco movement. I don't know how much of that is in India at the moment, that anti-tobacco lobby actually trying to influence the government policy.
Right. So I think, yes, Dr. Sham, you want to add upon? You're muted. You're muted.
I want to add here that I think among the different forms
Okay,
of
yeah. Can you hear me? No. Yeah,
Yes, we
yeah.
can.
Yeah, one of my close friends who joined this session, I can't say he or she, just for anonymity's purpose. He or she wants to quit smoking. So I would love to hear something from Professor Goel or Dr. Chiranjit or Dr. Raha, how to quit smoking. But nobody wants to listen to me. That's for sure. So if some of you can advise how to quit smoking, in the simplest terms, that'll be wonderful. That's all. Thank you.
Chiranjit, you were adding something. You were saying something.
Yes, yeah, yeah. I think on the different forms of tobacco products, smokeless type, the chewable types they have introduced now, that will be very dangerous because it attracts the first time users like the childrens. And, they hook onto them on the addiction. So it is the worry's part. And under this the quitting part, I think as many addiction as tobacco users also a kind of addiction. So the I think he or she can taper the uses, then gradually then she can come over on his addiction or her addiction. Also she can help sought help of psychiatrist or psychologist, I think.
Okay. So, yes, I think there were 3 points. One raised by Dr. Sandeep about the efforts in India. So, right, so UK has made the efforts. I know in India, we had been very intensive actually. In India, there are a lot of efforts going on, especially in the last decade. Lot many things happened. India was one of the first country who actually signed a framework convention of tobacco control. It was a treaty which was negotiated under the auspices of WHO in 2005. And India was, I think, the seventh or the sixth or seventh country which ratified WHO Framework Convention. It was the first public health treaty globally, anytime, which happened, in which all 193 countries actually took part. And you might be surprised that two major countries, United States, America, and Indonesia, these are the two countries in Indonesia. Why I'm saying Indonesia? Because Indonesia has a very high prevalence of smoking and tobacco use. And why I'm saying United States? Because US is one of the country which is actually lobbying for many things, but they have not done their homework in terms of signing or ratifying framework convention on tobacco control. As far as India is concerned, it was the one of the first country. Then it made law even before signing the FCTC. So the National Tobacco Control Program was, although it was there in 2008, but in 2005, in 2003 actually, they made this COTPA, Cigarette and Other Tobacco Product Act. So it was, you can see that India was among the front runners in tobacco control in last 2 decades, and one of the first country who banned ends, banning of electronic nicotine delivery systems. Many, very few countries have actually banned that. Many people have regulated it. As Dr. Raha has said, regulation means like it's not being smoked in public place, it's not being taken there, but it can be taken there. So some sort of regulation. But here it is banned in the sense that nobody can either sell, nobody can manufacture, nobody can smoke. And India has one of the other stringent law under the Child Protection Act, where anybody selling electronic cigarettes or electronic nicotine device can be imprisoned for 7 years. So it's a very long this thing, and fined for 5 lakh rupees. And in Punjab, they have done the raids, and few people are under bar just for selling electronic nicotine, this electronic cigarettes. So something is happening quite good, and many good practices are there. I think we can have a separate sessions on good practices, like we have yellow line concept, where within the education, within 100 yards of educational institution, they draw the yellow line, and nobody can sell within that 100 yards of this thing. And regarding taxation, yeah. So I think there are many things which need to be done in taxation, but we are doing that. I think taxation initially was the state subject, but now since GST has come, it has become a central one primarily, and it is I think not to the tune of WHO, but it is coming nearer to the WHO value in taxation. Only on cigarettes. In BDs, yes, we need to do much more on it because many people are consuming these BDs as this products. So this is just the status of something which efforts which India is doing. Now coming to Dr. Sham, question about quitting tobacco use. Again, as tobacco is very close to heart, similarly, I would love to counsel some patient on quitting. So I think there are multiple methods of it. The two primary methods are behavioral counseling and pharmacological. As Chiranjit has said, I think two things: behavioral and pharmacological, and combination. I am fan of this because there are many reasons to it. Behavioral counseling is sustainable, to the sense that if you just change the behavior of individual, so that will continue for long. If you just keep on pharmacotherapy, after some point of time they may return back. And second thing in behavioral is considering the type of population which is there. They can't afford this pharmacological therapy, and there are multiple medicines to it which need some physician's advice for it. Now, how to do it? Chiranjit has said about gradual tapering of this thing, cigarettes and tobacco products. There is no quick fix method which has been there, but people say about one thing about cold turkey method. Cold turkey method is you just throw the cigarette pack in the deep nala or deep drain, and then just adopt few methods which I'll be telling you next. But that particular, there are three prerequisites for it. One, whenever you are counseling a patient, always counsel a family member along with. So that is must. You should have a champion or a family member who's willing to support. It can be a family member, it can be a peer where that person can share about that. So that is must, because you can't individually counsel a person because they may suffer a lot of things. If a person is a very habitual smoker, which might have a lot of withdrawal effects after leaving smoking, so there should be somebody to counsel or somebody to support. So that is first thing prerequisite which we require. Second thing which we say to these the smokers or uh, the people who are addicted to smoking is to keep cues away, like cues of smoking, like the ashtrays, something which actually incites them. Like they should be away from those people who are actually smokers, who are peers, and keep those ashtrays, keep cigarette packs, and they should not actually see that. So that is another thing which we advise them. And third thing, what I do personally, like whenever I used to visit to any place and I hire a driver with a cab, so I always keep some photographs in my mobile camera, and they are very dreaded photographs of cancers, of lot of health, the problems. I think I always keep it with me. I keep on showing them that these are the things which will be there. And as Dr. Sandeep has very rightly said, that I always try to calculate the same method as Dr. Sandeep has pointed out, that the number of rupees what they are spending. So they don't realize that they are spending almost half of their wages in smoking. And when I used to calculate for them, then they realize that, yeah, I am spending half of my wages. And then I used to tell to them that who will take care of your family if you don't have money, because you are spending the money here. Second, you are deteriorating your lives, and you can see these images which is clearly depicting that uh, you might be suffering from some of them. And The third thing which I usually keep is the tailored advice. Like I see what type of, if that patient is a like young girl, so then you have to behave. You can't tell them that you will die earlier. She will not worry about dying. She'll worry about wrinkling of skin. She will worry about her beauty. If it's a cardiac patient, they will worried about that particular, like they may not suffer from any cardiac episode later on. If that person is a poor patient, then I will calculate this thing for them. I'll try to emotionally tell them. So I think these are some of the things, and then rest. I think these are small things that you keep those chewing gums, normal chewing gums with you, which you keep on chewing. Then you can keep elaichi, or you can keep long, which you can keep. But I think these are just supportive. What I'm trying to say is, main thing is the brain. You have to touch that chord in the brain where I think that person is more sensitive at. So there is no generic solution, Dr. Sham, for, like, it depends on patient to patient. It's a very tailored advice which we try to give to patients. So I think yeah.
Shangita, you wanted to say something?
No, I'm just saying that that's very good tips, Sonu Goel. Of course, the behavioral modification and having a peer pressure is something which is practiced quite widely. And cold turkey usually happens in our patient when they come into hospital. Obviously, they can't smoke in the hospital, and we do sometimes will prescribe them nicotine patch depending on how heavy they were a smoker and the dose of the nicotine patch. But peer pressure and behavioral therapy is very, very useful, and it is difficult to give them the dreadful pictures you carry in mobile phone, but I think it is quite effective, because when I used to do general medicine, the best time to tell the patient to stop smoking were when they were in coronary care unit and just suffered a heart
Right,
attack.
right, right. I think that's the opportunity.
Yeah.
Dr. Sham, can I add something?
Please, please.
Yes, sir.
India is developing its capacity for tobacco cessation. There are 310 dental colleges, and Dental Council of India mandates that each dental college, in its own place as well as in its outreach clinics, have tobacco cessation clinics. And Indian Dental Association with Ministry of Health and Family Welfare have collaborated and in issued an operational framework for tobacco cessation utilizing dental colleges. And one of my study, I'm evaluating the functional capacity of dental colleges and the tobacco cessation clinics here. So eventually, I think India will develop a grand scale capability in tackling tobacco. As of now, yes, as Dr. Goel mentioned, that individual behavior, but we all know, coming from the having background, we know the neurobiology of addiction. We've heard, I quit 1,000 times. So the neurobiology of addiction does not permit the current situation, but tailored practices are available, and dentists are being trained for that at the national level through ICMR. Especially the public health dentists and those in the oral medicine department are getting trained, and National Institute of Cancer Prevention is building capacity through uh, non-medical graduates as well.
About cold turkey method, I wanted to say something. I'm an nth generation smoker. My father smoked. I smoked. Of course, not. I was not a, I mean, heavy smoker. My father smoked. My grandfather smoked. My great grandfather smoked. And likely that their fathers also smoked. So it's not. The way I saw my father stop smoking was one day. mm, I mean, he just threw this pack off. Okay, I'm not smoking anymore, and then I saw him grasping his fingers and knuckles and no, I'm not smoking. I'm not smoking. In that way, I mean, in a single shot, he smoked. He stopped. I also stopped nearly the same way that I said I'm not smoking. Then, if I had very strong desire to stop to smoke, as to go and buy a full pack of Marlboro, smoke one cigarette and throw the rest of the pack, which is a big drain on my pocket. That if I throw it in a garbage bin, there is all kinds of other things I can't pick it up from there. I mean, there is even dog's excreta I put over there, so I can't. It's a very simple thing, and in a way, it worked. That I I can't say that I've completely devoid of smoking. I smoke maybe one or two cigarettes in a year, or in every 2 or 3 years. I mean, I'm in a mood, and I smoke one or two cigarettes. That's it. I mean, I want to say that I love smoking, but I stopped smoking. I must confess that. It will be. I mean, it's possible that you love smoking, you enjoyed smoking, but you still stopped smoking. It's in the same way probably all other tobaccos, like khainis or gutkhas or anything else. Second thing is that I have many. There is only one friend who is a smoker, tobacco user, and who came and joined this session. But there are at least 10 others whom I requested to come and join this session because they're either khaini or gutka or pan or other users of tobaccos. They somehow fear that they don't want to join this session. There is a mental barrier, and at least 10 people I said that you must join this session. It's not something very high-fi, not about genetics, not about this and that. It's a general discussion how we can. So they don't want to. There's a mental barrier. I do not know. That is one of the things which I wanted to get rid of through this webinars.
Yeah.
Let's break this doctor-patient barrier. Let's bring some common platform. And even then, that they fear, they know that they don't want, they shouldn't smoke, or they don't shouldn't chew pans or khainis, but they fear to come and listen to
Yeah.
this.
Yeah. Dr. Sham,
To
one more thing I just want to add, that those people whom I counsel, I have the drivers' phone numbers of those drivers whom I counsel. I think 7 or 8 people, way back 8 years back, 7 years back. I still have their numbers. So what I used to do is I used to call them, and like maybe every second month or third month, and ask them that whether you are still smoking. So they say no, I have stopped it. I don't know. There might not be any reason to say anything wrong. So I believe on them that they might have stopped it. And then, how are you feeling? So they feel young, and they feel this is what their actual anecdotes are. After leaving smoking, I feel young, I feel energized, I can do more work, which they initially feel that after smoking they do more work. Because the laborers and more people, why they smoke? They smoke because they are doing more work, and they think that after a kash, after a this thing of smoking ka kash lagane ke baad, they can work better. But it is just a matter of few days and few months, after which you are averse to the smoking. And many people have said
yeah,
that I don't want to join that league now, because I actually am very averse to that smoking. So this is exact word which people have said. It's just a matter of taking a chance and believing in you, believing in yourself, that yes, many people have actually quit smoking, and one can quit.
yeah, it's obviously
Sometimes
possible
people,
and quick. Please, Papidi.
excuse me, go ahead.
Hello, Papedi, please go ahead.
I just wanted to say some people smoke just out of curiosity, you know. I was coming once from USA to India, and my German professor said, I asked him, what should I bring for you from India? He said, can you bring me a bunch of bidi? I just couldn't believe that he wants some bidi from India. So it was just out of curiosity he wanted to smoke bidi. Lot of fun for him. I have nothing to say.
Yeah. So I think we can go further. Maybe I think a good discussion on how to quit. And I think we can, if somebody wants, Dr. Sham, you can give my number in case somebody wants to quit. I'll help them out, although
I will
it's a
take your
physical meeting which actually help. But we can
Mr.
still
Goel,
work.
Mr.
Yes,
Goel. Hello, Mr.
yes,
Goel.
yes. Yeah, Mr. Chatterjee, yeah.
Can you hear me? Am
Yes,
I
yes.
okay?
Yes, we can hear you.
My name is Rupayan Chatterjee. Actually, a couple of days back, I was talking to Shamda. I am addicted to smoking for the last 30 years or so. Uh, I am 52 years of age now. So I really want to quit smoking. But the point is, my blood and my brain wants that nicotine. So probably this is the reason why I am unable to quit. Knowing fully aware of all the ill effects of smoking, particularly the heart, lungs, but still I am unable to do so.
Sir,
Mr. Goel, I'll take your number from Mr.
sure.
Chakravarti, and definitely I will get back to you, sir.
Sure. And I think just want to say two sentences in addition to what has been said. That Mr. Chatterjee, nobody has died or nobody has actually suffered if they want to quit. Like if you quit, so nothing will happen to you. It's just a matter of few things which you will suffer. Like you may have withdrawal symptom, you may have tremors, you may stop eating or something. It's a matter of few days. We just need to remember this particular thing in mind. Just have to bear. If we are ill and if we are on bed, if we are suffering from pain, then also we have to be on bed for some period of time so that we walk away healthy. So one thing which I always tell to like the smokers, that the good part after quitting is you can be healthy and you can be the same person. It's not a matter like your heart or lungs have that it cannot return back. Most of the things return back to your own. And if I say there are chronology of events, like after 1 day, what will return to normal? After 7 days, what will return to normal? So I think there are a lot of things which you will just see, and then you will be encouraged and encouraged to quit smoking. And definitely, I'd like to like listen to you, and we can have some chat. And I think I will.
Thank you, sir.
One thing was I wanted to comment, Rupan Babu, that have you actually tried the nicotine patches in doses, depending on how many cigarettes you smoke? For example, you smoke 20 a day. So going as a cold turkey, dropping 20 to 0, you may get quite a lot of withdrawal symptom from caffeine and nicotine. But if you go to the patches come in different strength, and I'm sure they're available in India, and depends on how heavy you are smoker you smoke. The different dose of patch. In UK, we use 10, 20, 30 milligram patch, which is a daily patch. You put it on, and it's a prescribable. In UK, it's prescribed patch, but I'm sure you can buy them in India over the counter, and you can put the patch. Say, for example, you smoke 20 a day, you may need 10 to 15 milligram patch every day to start with, and then you drop the patch off completely. But obviously, as Dr. Goel said, that having consultation on the phone or on the video chat and having that behavioral stimulation and support will be also very important.
Right.
Yes.
So what I want is that we
Dr.
should
Taha,
have a
I
good
think I
plan.
will try that patch very soon, maybe probably this week only. And with the, I mean, I will follow up with Mr. Goel also, with Dr. Goel also. And let's see. I
Yeah.
really want
All
to
the
quit
best.
smoking 2020.
All the best.
Thank
Looking forward to
you.
hearing from you, Dr. Rupian. Yeah, after some time. Yeah, Mr. Rupian, yeah.
Please, sir. Please, sir. Please continue, sir. Please continue,
Great.
sir.
So I think there are few things which I want to bring to this floor. Is people usually ask few questions like over last 10 years I have been hearing few questions, and this might also emerge in this forum also, that why don't government, if that is really a problem, if the smoking and tobacco is really a problem, why can't it ban overall tobacco? Why can't government ban overall tobacco? Why it is still being sold on various shops and all those things. So this is a very common question which we used to hear, and I hope Chiranjit might also be asking this question from me after a period of time. So shall I answer this? Try to answer this question which people like to hear.
Please go ahead.
Yeah.
Yes.
Please go ahead.
So yeah. So I think as it has been now clear that tobacco use is not only a health subject. It's not only a public health subject either. It's a political subject. Why I'm saying it's a political issue is because there are 13 ministries, 1 3, 13 ministries are involved in tobacco. That is Ministry of Taxation, Agriculture, Forestry. So agriculture because growth is there. Forestry is because the leaves of tobacco. How the leaves, how this tobacco is grown. It is basically Nicotina genes, Nicotina tobacco or Nicotina rustica, the leaves of that, and it is being cured. Cured means there are some woods, 70 kg of woods is being used to cure 1 kg of tobacco. So you can imagine that how much trees we are like environmental damage which we are doing for this. As I was saying, the Ministry of Education, Ministry of Taxation, Ministry of Excise, Agriculture, all ministries are involved, and Health, Ministry of Health, which is a very small ministry. If you know the political scenario anywhere in the country, so Health Ministry is a very small ministry with a very small, minute budget, with a very small say. But tobacco is being given to Health Ministry, and despite a lot of convincing, Health Ministry can do much because people like country need money. They need money by taxation. They need money by this thing. So, and you might also be surprised with the fact that we have a tobacco board in the country, tobacco board, which is promoting tobacco. So government has a tobacco board along with the National Tobacco Control Program, which is housing it. So the purpose of tobacco board is to actually promote tobacco in the country. So that is another thing which is there. So it's, and you might be seeing that there are various companies like LIC. So these insurance companies are also are investing in the shares which are tobacco shares, ITC. So shares are there. So there are a lot of things which are happening simultaneously because Health Ministry has a limited say. So this is one reason why we are not able to actually ban tobacco. This is one. Second reason is, like those countries who have banned tobacco, there is only one country in entire world which has banned tobacco, and that country is Bhutan. So Bhutan is the only country which has banned tobacco. And you see what is the prevalence of tobacco use in Bhutan? So prevalence of tobacco use in Bhutan is around 30-35%. So despite a ban, a complete ban of tobacco, no production, no consumption, nothing, and then also the prevalence is as high as 30% or so. So just by banning a product will not guarantee that it will not be consumed. And many of you have seen like banning of alcohol from some states in our country, and then you can see the prevalence actually rises. So banning is not a solution. And so that's why these are the two major reasons that health department doesn't have the entire say of banning. And second thing is, just without changing the behavior and just banning things will not work. So these are the two reasons why tobacco still is not being banned. But there is a golden line here, uh, is we are working towards tobacco end game strategy now. So the tobacco end game strategy is itself a bigger subject, and many countries are working towards it. And it says that after a certain year, they have kept a timeline that after 2025 or 2030, anybody born after that particular date will not be able to purchase tobacco product. So this is one of the strategy of tobacco end game, and India is also working towards it. It's in the infancy stage, but yes, people are working towards tobacco end game, and that will actually end the entire this thing tobacco product in the entire country. And many countries are in advanced stage, like Australia and many other countries are in advanced stage of this tobacco end game strategy. So I think this is another fact. Yeah, Dr.
Can I
Sonu.
just mention one thing as
Yes.
well? Is also tobacco advertisement, isn't it? That tobacco advertisement in many Western countries has been completely banned from sports, from stadiums, from television, newspaper, news media, including internet, Facebook, whatever. So the banning that also, because more exposure you get to the product, more likely that you will continue. So that again, actually relates to your comment, Dr. Goel, about the taxation and the money generated from that.
Right, right.
Yeah, Dr. Goel, one small observation I have made, and that study also you can say, the younger generation of these days, particularly, I mean, the children of 20 years, 25 years as of now, they are not hooked up to smoking or they do not have any sort of addiction towards smoking. Actually, smoking was considered as a status symbol in our younger days, in the 80s or so. So perhaps that is one of the major reasons why it has shot up into such prominence.
Right. So
And
I
thereafter
think
it has
now,
come into a regular habit.
yeah,
And some fools like us were trapped throughout the life, and we could not come out of it.
Mr. Chatterjee, you're right, that right now there are some newer things which are exciting the youth generation, and that are
If
these
you
electronic
could share
products.
some, if you could kindly share some statistics on this, the smoking trend, which is noticed in the younger generations. Say, for example, the children born after 2000 in this millennium. What about their habits? And what about their thoughts as well?
Yeah.
How do they perceive smoking?
So just to I think there are two surveys based on which I can give my thoughts, and that is Global Adult Tobacco Survey, which is being done globally. And the first survey was done in 2009-10, and then it was second survey was in 2016-17. So it's a global wide surveys, and in India also it was conducted among the population. Somewhere around 80,000 population was taken from the entire states. So you are right that now it is no longer a very good status symbol. And now what is the status symbol is, like they are excited to some newer products, like some hookahs. So people, the younger generation, the modern generation, are excited to hookahs, which were there popular before, quite before, and now it is again become popular. And second thing is about this electronic cigarettes. So these are two popular things which are there. And as far as the statistics goes, that the age of initiation has increased. What is age of initiation? Age of initiation is when the person starts smoking in his life. So initially it was around 17 years. Now it is around 18 years. So that has increased. So that is a very good sign that people have increased age to 1 year. 1 year is a good time if you're taking the mean age of individual. So initially the people used to start smoking earlier. Now they start delaying it. And if you see, up to 25 years, 80% of the people start smoking. After, if you just prevent that age up to 25 years, the person, there is a very likelihood of a person start smoking. So this is what we need to do. So I think you're right in certain sense. We are saying that it is still not a status symbol. It is still has, because something in the peer pressure and all those things, they have something to do. But now the newer things are coming up, which is taken over the cigarettes or BDs. Dr. Sham, you want to say something?
Yeah, you very rightly pointed out that which we didn't have in our early youth, the hookah bars. In
Yeah.
Calcutta, the hookah bars are so much popular, and even very, I mean, kids of something 20, 25, they call before their parents that, hey, we are going to go to a hookah bar, I mean, group, want to go there. And then later, okay, don't smoke too much. That was some kind of mild caution. They say that go to a bar and about this exactly hookah bar. I,
Allow me to put forward my view.
please,
Hello?
decide.
In Calcutta, uh, as well as in other parts of India as well, what you said, men, I do not hold it good. People do not act or react like this with their children's adolescence of request to going to a hookah bar. I mean, I have never come across any such family, or nobody is known to me. Hello?
Yes, we are listening to you. Yeah.
Nobody is known to me that, okay, you go to a hookah bar, not. Be it Calcutta,
I
or
have,
be
I
it
have, I have
anywhere.
seen.
Anyway,
It's not only hookah bar. It's also about drinks. It's also about
yes.
drinks.
No,
I have seen parents are okay, even with 20-year-old kids. Parents are okay that they drink something, and they, with a caution that don't get out. Don't.
it is for the this theory will hold good for the entire spectrum of vices which are available in the world. Be it smoking, be it drinking, be it any other thing. Be it any other thing. You know,
No, it's true. It's true. What my contention is that
no parent would encourage their family members or their younger ones, and rather encourage them to go to a hookah bar, or to, with a folded hand, request, do not drink so much. Well, there is an age for everything. So maybe this case which we have encountered, that gentleman, I mean, that boy whom he requested, he must be of 20, 25 years of age, and he must be on his own. He must be working, or uh, attending to some sort of business or the other, or into a profession. So therefore, as a father, he might have requested gender. This is not of a
what I wanted to mean that in our youth would not get that courage to say to our parents that I'm going to hookah bar, I'm going to
in our childhood and our adolescence. The system was totally different. The
Yeah,
uh,
agree.
we were not that much tech savvy. So many things have changed.
Yeah,
It's just I'm going to see change.
agree.
So have to accept all these changes and take the positive part of it.
No, I agree.
Yep.
I agree. It's not that I don't agree. Okay.
I'm just considering the time. I just wanted to make one more point here to Rupan's and Dr. Sonu's. The present generation, or even before that, there is a lot of enticement with other products like smokeless tobacco products, which are given in the disguise of more freshness to the teenagers. So that is an important aspect, and smokeless tobacco is one of the initiators which lead to smoking later part of life. And I do not know much about the statistics in the children, but there are studies which say that around 5 million street children are addicted to tobacco before they reach 18 years of age. That is 1% per child in Delhi, where it conducted in some children. So my point here is that although it is a problem, a global problem, but developing country like ours, smokeless tobacco, especially among the youth and the women, is a major problem. So tobacco is usually initiated in the form of smokeless tobacco, which is carried on to smoking tobacco in the later part of time.
Right.
Yes, right. Which I mentioned earlier, so that this chewable tobacco is the very worry part because it introduces you to the tobacco use for later part of their life. So that is
Yes. Yes, that is one of the, and one more important thing that we need to focus is tobacco. We talk about nicotine. Nicotine is an addictive substance, but it is not the nicotine that causes the most of the. Yes, addiction is important to induce a lot of other things, but the components within tobacco are important. Like Swedish tobacco, which follows the Gothic rules and regulations, is not carcinogenic, whereas in Indian tobacco, which has no regulation, that's an important thing. Apart from nicotine addiction, there are the other compositions which are more carcinogenic in India, whereas it is not in Swedish. So there are a lot of issues that needs to be dealt. We cannot compare our countries, and even if our prevalence is reducing 1%, it doesn't mean that we are meeting the needs. Enormous. I mean, I just wish and pray that our research practice area, enormous work has to be done in tobacco in India because of the social acceptance, cultural acceptance of smokeless tobacco. And moreover, another issue is aracanate. Aracanate is the use of smokeless tobacco is subdued by aracanate use, which needs to be addressed. So this is one part of my study.
Madam, what juice are you? I couldn't get. I couldn't get, madam. What is Can juice?
The aracanate, the betel nut.
Betel
Okay.
nut. Yeah.
Betel, the betel
Fun
nut,
and betel nut.
use of
Yeah.
smoke, like we can see that Dr. Sonu Goel was telling about the tactics of the tobacco industry. This is one tactic of the tobacco industry where it gives a complimentary sachet of tobacco with
Yeah.
aracanate product, so that people, tobacco regulations say that they cannot mix aracanate and tobacco, but when a tobacco industry conducting tobacco cessation in my clinic, and people would come to me telling, okay, this is available to us, what do we do? It is at a less cost, do we throw it or use it? Our mentality is irrespective of what it causes. People do not know. Our people are innocent, ignorant. 30% of the population is below poverty line. There is a lot of illiteracy going on. What do we are talking about health awareness, which is as Dr. Sonu mentioned, hunger pangs. Even today, people, the agricultural laborers, stuff their mouth with aracanate and tobacco to control their hunger. Not only hunger, water is not available in the agricultural fields. So some of my participants were saying, how do we stand in that hot sun without water for a whole day of 8 to 10 hours in the fields? Entire day they stuff their mouth with this. So it is socio-political, cultural, economic problem. So it needs, today we are 10 people talking. We need to take this 10 to many layers and to the, my thoughts is that take practice from research to practice to the grassroots, which is the rural unreachable areas.
Right. And I think just to extend Dr. Priya's thought, just one point, Dr. Sham, because
Yes.
as I think she has told rightly that tobacco industry is using various statistics, and one of the statistics which she has pointed out, there are multiple of it. And Government of India has, there is a strategy known as Article 5.3 of Framework Convention on Tobacco Control. So that Article 5.3 of Framework Convention of Tobacco Control states that any government employee or any employee which is being employed by the government cannot interact with tobacco companies directly or indirectly. If that person is interacting, so that has to be informed to the authorities that there is an interaction going on, and that interaction has to be recorded. So that means that we can't interact with the tobacco companies as such, or the tobacco company individuals. And the second point which I want to reiterate here is about the advertisement, which Dr. Sandeep has pointed out. Not only the direct advertisement, but also some indirect advertisement, like uh, just by will cigarette. Even if will cigarettes is not visible, but the pattern which the will cigarette used to use, that should not be there on the shops. So that is again punishable under KOTPA. And one more thing which I want to suggest and reiterate to the listener of this particular presentation is we should start banning or not using, not, we'll not say ban, but not using ITC products. So what are ITC products? Some of which are like Ashirwad Atta, which has the ITC logo on it. And you can see like Sunfeast biscuits and this Bingo, Yippee. So all these type of products. I'm saying that because the thing is, these tobacco companies are actually promoting this in the market just to have their name consistently present in the generation, because their name is no longer the cigarettes, so they want to keep this name available in the market. So these type of RTC products, and even I think there is a notebook, I forgot the name of that, there's a beautiful
Classmate.
Classmate, yeah, Classmate. So I think I never,
So
whenever I
this,
go to market, so I never use this type of products there.
so this brand name Indian Tobacco Company or Imperial Tobacco Company is always visible.
It's
So
always, they want to keep that name visible.
yeah. Okay, I'd be interested to. There are three participants here. Professor Papianandi, who has been the director of JBNSTS, Jagadishpur National Talent Research Scheme for more than 10 years, and Professor Emeritus of Department of Physics, Jadavpur University. I want to. It will be very nice to hear her perception about tobacco use in youth. There is Baishali Nandi, who is a school teacher, and she must be knowing. She is from a village in North Bengal, and there is Atrey Kundu, who interestingly, a very young, would-be doctor of the, I think, of the age of 18, 19, and how you perceive this tobacco. So I'll be interested to hear them. So can you please tell something about it? Maybe you choose any one of you start something about uh, talking about use of tobacco in general in this rural environment or amongst students or everything. Could you tell something? Papi Edi, are you there? Papi Edi? Okay, Papedi probably is not here. Bushali, can you tell us about use of tobacco in your?
I'm here, Sam. I'm here.
Okay, can
What I
you
say?
yeah, can you tell us about tobacco use in you're from Jadavpur University, you're from Jagadish Bose National Talent Search Scheme. You have seen a lot of life with young kids and their use of tobacco.
Yeah, Sham. I see one thing. Notice one thing. That smoking has lessened a lot among the boys, but the girls are picking it up. In front of our university, when I get in, I see
Absolutely
the
right,
girls are
Papedi.
smoking.
Absolutely right.
Girls are smoking. Yeah, Rupan Babu, you think so? Girls are
Absolutely right.
smoking. This
Absolutely,
is
madam.
a
Absolutely, madam. Right.
status symbol for them. But the boys are not smoking that much anymore.
Yes.
Okay. Okay. I have nothing to say.
Yes. So moving on. So can we move on some?
I just wanted if Vaishali has something to say or Atri.
Uh, yes, sir. Like I lived in rural areas of some of North Bengal, so some of not only my friends, some of my teachers are also involved in smoking, like some of my bio teachers who actually teaches me about the ill effect of tobacco. They are also smoking. I'm just surprised how just and like Papia ma'am said, a few of my friend, I mean girls are also smoking. So it's,
Yeah.
although they know about its ill effect, and
How do you
that's
think
what
that
they
what kind of feeling they have when they're I mean, what attracts them to smoking? What attracts girls?
actually actually they just experienced, they just chill, not just chill or first experience or does like it.
Yeah.
Yes, I think that is what the cigarette company, tobacco manufacturer company, that address that they use this like macho man kind. That if you smoke, you are a man. Means like if you are smoking, then it is a status symbol. That is what the tobacco companies are targeting. So that's how they market their products actually. The Marlboro country ads means they used to the way they package that it gives them immense like the sort of power that okay, if I'm doing cigars, that I am kind of some powerful man. Like even in the movies they used to show that the main protagonist heroes doing cigars and like that they, all these affects us not like Dr. Well has said in the start of that the tobacco affects us and we also affect the tobacco how it is being used. So like that way it is also psychologically connected. That is what being
Do
used by.
do you know that I think it's probably known that the Marlboro man died in lung cancer. He had lung cancer. This Marlboro, this man sitting on top of a horse and smoking with a cowboy hat and leather jacket. He died in lung cancer.
Are you sure, Tamda?
Yeah, I'm sure.
Okay.
And Bushali, do you have something about smoking in rural, smoking or pan or chewable tobaccos in rural areas? Could you tell me something?
Consumption of gutka among my students bothers me a lot. It dirty our classrooms and we do not feel good on how to control them. It's a big deal, and I have heard counseling part, and I'll let's see. I will do my best among my students. Let's hope for best. Thank you.
So I think right. Uh, I think we are towards the end of this webinar, which I think Dr. Sham. Um, so there are few messages from my end, and then I think you all can supplement. Like I want to give 3 or 4 messages to the audience right now.
Please.
Uh, I think the first message which goes is it's basically easy to stop initiation of tobacco use rather than to quit, because
Yeah.
quitting is hard. Quitting is
Hmm.
very difficult, and it
Yeah.
takes a lot of courage. As Mr. Chatterjee has rightly pointed out, that he has been trying, and I think it is quite difficult. And I must, I echo with the thoughts of Mr. Chatterjee that it is difficult, but not. I'm not saying that it's impossible, but it's difficult. So it is always easy to stop initiation. So that's why the school education program, and we need to make our child ambassadors in basically in these type of movement. So that is one thing.
Yeah.
Second thing is, although quitting is difficult but not impossible, we have seen
No.
many people quitting, and by various methods, as Dr. Sandeep has rightly pointed out, this patches work. And I think if along with it we can have a quit plan, a detailed quit plan, so that works, and that will contain, of course, behavioral intervention coupled with the pharmacotherapy if needed. And pharmacotherapy should be given in presence of like it should be some physician who should be advising the correct dose, the tapering of dose, and all those things should be there. It should not be taken unattended and without the act of the physician. That is second. And the third point is the tobacco industry. We should be very wary about these tobacco industry who are making profits out of our lives. And as tobacco is the only killer or only poison or only thing which actually only product as such, we say, which kills half of its users. So tobacco is the only product in the history which kills half of its user, and around 8 million people die because of tobacco use, out of which around 1.2 million or 12 lakh people die who are not actually consuming tobacco, so by second-hand smoke. So that is again this shows. And another point which I want to highlight here, that tobacco is not only like is not being liked by the animals also, because if you make a we say bard, or we say that fencing, you make a fencing of tobacco leaves around your village, around your field, no animal will eat the leaves, and no animal will come near your. So, and this is the fact that tobacco is really dangerous, and even animals consider it dangerous. And uh, and wherever it is being grown, it consume all the fertilizer of the soil, it consumes all the fertility of the soil, and you can't grow anything in that soil for at least 3 4 years. So this is the real harm of the tobacco, and we
Yeah.
should shun the tobacco products at home, and we should make our at least our society or home as tobacco free home. So these are some of the messages from my end. You can all supplement by giving one message each from your end.
One thing I wondered that whether many of these things which you talk, it comes to some kind of a community intervention. That is, you support groups and this and that, and this could be very well done probably with the help of say through certain institutions like schools and colleges and clubs, particularly through schools and colleges, universities. It will be nicer to see that some efforts go over there, at least particularly on the side of not getting into tobaccos or not getting into the issues of I mean, eating or chewing or smoking tobacco. I mean, if you can have this intervention in the beginning, or or making people aware of that. Okay, particularly at the school level, which might go in a long way, that that the ill effects of tobacco chewing or smoking, gutka chewing or kaini, it could be probably, as you said, they defer at least the initiation age by a couple of years, or 2 years, 3 years, and then towards 25, and then you will automatically don't get into there. So I just wondered that if some kind of programs could be initiated in that way, where institutional level intervention in deferring tobacco usage could be initiated, or eliminating tobacco usage could be, telling these school children, telling the college students, don't smoke, don't chew.
Yeah, yeah, right. I think these are some of the interventions which are already we are working in some of the project areas, and I think we are having a Bloomberg initiative project which has been running for last 2-3 years now, and we are working in 4 states intensively. In the state of Meghalaya, one we are working in Odisha and Pondicherry and Telangana. So these are the 4 intensive states where we are working with their government and with the partners as All India Institute of Medical Sciences and NIGRIMS in these states. And we are working towards some of the school level interventions and some of the policy level interventions in these states. And as Dr. Chiranjit has rightly told, we have a resource center for tobacco control. All of you are encouraged to see that it is www.rctc, Resource Center for Tobacco Control, rctcpgi.org. So you can see a lot of circulars, orders, and lot of IEC material information which you want to see. So in that resource center, and shortly we will be having a basic online course on tobacco control, which we'll be launching in early part of next year. So we are already onto it, and for the persons who are really interested, so we have a comprehensive program of 6 months. It's a diploma certificate program which we are launching interested in tobacco control. So I think these are some of the updates which we are doing right now.
Yes,
Professor Goel, I sorry, Dr.
yes,
Chiranjit,
go ahead.
I just I maybe, yeah, the thing is that quite a lot of programs get them initiated. That could be probably one issue, that if there is a document and all kinds of resources, probably nobody will read them, nobody will come over there.
Mhm.
How do you take this message to people? That is something, and that is something I think with Chiranjit I have been discussing, that there are a lot of these chewing tobaccos in that area, like Tripura, and how these things mm, could be addressed. That is, yeah. Please, Chiranjit.
Yes, yes. So I was saying that we as motivator, we should not get demotivated while motivating others. So though we may see the response very less in early phase, we should not discontinue our efforts. We should continue our efforts, because the motivation thing, that it cannot be built over a day or a month. It should be for the long term effect. It should be continuous efforts. So I feel the village, the ASA, the who are working at the grassroots level in Indian health system, they conduct this village health and nutrition day. It can be incorporated this tobacco awareness against along with TB, that can be actually done. I feel so. Uh, so that the generation awareness generation can be widespread and gives continuous in the news.
Right. So I think Dr. Chiranjit, we had quite a good discussion, and I think I would like to thank Dr. Sham for taking this initiative again, and Dr. Chiranjit for joining with him, and all our colleagues for being a part of this discussion. And look forward to having further discussions in the future too. So I think anything else, Chiranjit, anything or Dr. Sham before we close?
Uh,
Dr. Goel and Dr. Chiranjit, thank you very much from deep of my heart that you accepted this invitation, and you have enlightened us very much. Excellent presentations, and I have talked enough all through this discussion. So maybe if some of you, maybe Boishali or Ratri or Papi Adi, if you want to. Shreyash has joined recently. Shreyash, who is now doing his MD at Tata Cancer Hospital, Mumbai, if he wants to tell something.
Um, Thank you, sir, for the introduction. I actually had a question in my mind. I'm not sure if it's just a stray thought or a musing, but if we know that from the numbers, the tobacco is such a difficult uh, habit and it is such a lethal habit, then why don't we bring it in the category of opioids like marijuana from the regulatory and the government side rather than having so many efforts from below to above? Why don't we push for governments just banning tobacco products? That would be much better to do it from top to the bottom level of the hierarchy. Just a thought. I would really like inputs from my much more aware seniors and colleagues about these issues because they are actually working at the ground level. And here I'm just observing certain things and just musing.
So I think, Dr. Sham, that is the thing which I was telling, that this is a
Yeah,
very common question which
yeah.
is there in the mind of everyone. And thank you, Ms. Shreya, for bringing it upfront. And a few minutes back, you have joined now. A few minutes back, I tried to answer this question.
Yes,
Yeah.
sir.
Um, yeah, so I think because this is without this, we used to say, without this question, our workshops are never successful. So this is a
Never,
very common
never.
question which people used to
Yeah,
ask. And
yeah.
briefly, just for your this thing, tobacco is not only a health subject; it is governed by 13 ministries, and health is just a small ministry which is being given this tobacco thing. So there are tobacco boards which are promoting tobacco, and there are many other ministries which are actually earning from tobacco. So that's why the health department is not able to although it is doing quite good, but still not able to convince people in 13 ministry not to earn revenue for their ministry. So this is one thing. And second thing is, like tobacco requires a behavioral change, and we have seen that the countries like Bhutan, which has banned tobacco, is not able to eradicate tobacco, and the prevalence is still high at 30-35% in there. So it's not about just banning which will curb the problem, but it's about more about behavior change, which will curb the
It's
problem.
about
So
awareness.
awareness, yeah,
It's
yeah.
about
So
awareness,
I
yes.
think these are the two reasons which I gave you in the webinar, that because of which we can't, it's not, I think it's not feasible. But still, we are working towards tobacco control end game. And you will see maybe your son, daughters may not be able to see tobacco 20, 30 years down the line. Yeah. So I
Thank
think,
you, Professor Goel.
Thank you, sir.
Thank you very much, Mr. Goel. You have opened up many, many new channels for this thing, and thank you very much.
thank you. Thank you, ma'am. Yeah. So I think I need to leave. Any other questions which is there? Any other thing? Chiranjit,
I
can you
think
close
we
now?
are, yeah, I think we are done. But we should continue the battle because it is a long fight towards to build a tobacco-free society, and we should continue this discussion. It should not end by today.
Yes.
Means in the many future we should do much with much more larger audience. That will
Yeah.
be
Yes.
I
It's
think
a
that should be the thing. And Dr. Sham, if
yeah,
I think we can arrange maybe or a bigger forum, something on
yeah,
quitting. We can
yeah,
think of a detailed session on how to
yeah,
quit. Maybe we can Mr. Chatterjee. Some people can come and maybe ask the questions, and I think we
yeah.
can have that session. So I think that will be really useful.
Yeah, I think one of my major purposes is to bring people and to interact with doctors, but
Yeah,
there is still a strong aversion that asking questions.
yeah,
Asking
yeah,
question is I mean it doesn't come to Indian psyche that I should ask a question.
yeah,
It
yeah,
doesn't come. Absolutely, it doesn't come. I mean, so the moment it comes that I have to ask question, people
yeah.
we need to make more efforts. Thank you,
Great.
everybody. Thank you, everybody.
Thank you, everyone.
Thank you,
Thank you. Yeah,
Professor Goel. Thank you, Chiranjit. You have
thank
done a
you.
wonderful job, and I'm very proud to be associated with you over the last 2.5 years, nearly 3 years. Thank you, Mapedi.
Thank you very much
Thank
for
you,
Thank
sir.
you,
Thank
arranging
you, Dr.
this.
thank you,
Thank you
Goel.
Chirag.
everyone from
Thank
devoting
you,
time.
Akshay.
Yes.
Thank you, Boishai, and thanks Somiran for recording this. I hope it goes nicely. Thank you, and,
okay. Bye.
and bye everybody.
Okay, goodbye.
Bye bye.
Bye.